one of the things that you're talking about is an evaluation or a reevaluation of best practices. And we do have a number of drugs such as that have been the mainstay of therapy and some newer ones. So ACEs, ARBs, now you have the ARB with the neprilysin inhibitor, ivrabidine, and so on. And so how do you see those fitting into the best treatment guidelines?
I'm going to jump in just for a second, and then maybe I'll punt this to Nihar for a minute. But clearly, there is a historical approach, which is really the use of ACE inhibitors and beta blockers. I mean, those are the anchors of therapy, and they're very, very good. But we've been able to add to those therapies. And what I actually see in patients that come into my coronary care unit is they may have been on those standard of care therapies, the older therapies, which of course have the advantage of being generic and very inexpensive. But there's an underutilization of therapies that have been actually shown to add incremental value. The combination of a neprilysin inhibitor with an ARB, sacubitril valsartan, has pretty impressive data, in my opinion, from the Paradigm trial. It's still being underutilized. Mineralocorticoid receptor antagonists are underutilized. And I think we've got to probably do better about using the full continuum. Now, one of the problems that we're going to have to talk about is the pill burden. If you give people everything, the next thing, they'll come into my office and they'll say, I'm taking 240, pills a week. And people don't like that very much. And so that's certainly an issue. But I do think we've got to progress now. And adding now to the armamentarium, and going to be the focus of some of our discussion later, that is the very impressive data for the SGLT2 inhibitors. Well, you're going to have to add that now. All the data on SGLT2 inhibitors is when they're added to optimal background therapy, not as monotherapy. And so now we got a whole constellation of drugs that we're going to have to use in these patients. So Nihar, your thoughts?
Yeah, Steve, no, I think you made so many important points there, and I want to pick up on maybe just on a couple of them. I think first, all the therapies that we're talking about are for the reduced DF or the systolic heart failure patients, right? So yet the preserved DF patients remain a mystery outside of sort of blood pressure control and other things. We don't have good therapies there, and I think that's a theme that we'll come back to, I think, later on. And so in this world of systolic heart failure, we do have a number of therapies across a number of classes. And Neil, I think you touched on them, beta blockers, the RAS inhibitors, the mineralocorticoid receptor antagonists were sort of the cornerstones. I mean, they were sort of the mainstay of therapy. And then in addition to those, we've developed a couple over the last number of years. Ivabradine, we've seen the neprilysin inhibitors, and now the SGLT2 inhibitors, amongst others. And I think while we do have this expanding array of therapies that are available to us, and I think to Dr. Nissen's point, the SGLT2 inhibitors and the very impressive data that we've seen for them has been amongst patients that have been very, very well treated with background sort of standard of care heart failure medical therapy. And I would not discount the fact that we have a long way to go in our clinical practice to try and mimic what has been done in these trials. I mean, we've seen data from recent registry studies where about 1% of patients with systolic heart failure are actually on standard triple therapy with beta blocker, RAS inhibitor, mineralocorticoid receptor antagonist at the doses that are recommended by our practice guidelines. And so, yes, I'm all for seeing what is out there and seeing what has emerged. I think there's a lot of reason for excitement there, especially with the SGLT2 inhibitors. But we should not forget for a moment the fact that there is a lot of work for us to do in terms of, each of our individual practices and panels, to health systems, to payers and plans. How do we really get people on best medical therapy, which, to Dr. Nissen's point, we know is associated with helping people live longer and feel better. And I think, you know, there's so much important work to do on the medical therapy side. And I think our excitement for that is then only, you know, stimulated further by, you know, the arrival of new therapies and new classes with very, very impressive data.
And, you know, I think Jaime is going to talk about this, but, you know, I would just add to that, that keeping people out of the hospital has enormous economic value. I mean, you know, hospitalization is not inexpensive. And so when we have therapies that we know prevent recurrent hospitalization from heart failure, you know, getting people on those therapies has to be a very high societal priority.
Yes, Dave, completely agree with that point, because again, it's not about being short-sighted and saying, what is the cost of a medication? It really is what's the actual value that that medication provides to the patient and to society in general. So keeping people at the hospital is enough to justify making that investment when it's important to, again, to public health and the individual health of every single one.
And could you go a little further and touch beyond that? I'm going to ask you to start and then open up to the other panelists about how you look at quality measures. So there are quality measures around CHF, but there are quality measures around hospitalization and readmissions and so on. So how do you look at those from a payer point of view? And then I'll ask others to weigh in at how their institutions are implementing or evaluating those.
Yeah, there's not a single answer to it. I wish we could say, you know, this is the quality measure that everybody's going to follow. But the reality is that depending upon the system or the context or the environment, there are different ways to look at it. We're still, as I said, unfortunately, in many ways, it's still paying for hospitalization, it's still paying for medication, still paying per visit. And I'm hoping we are doing some work with lower cost opportunities. For instance, the Optum Care, which is, as you know, is part of United Health Group. We have close to 60,000 providers. We're implementing protocols that are EHR driven. So the idea is to standardize or minimize the reduction in variation of care. And we also try to take, you know, more of a proactive approach. We have a very focused look into who is, for instance, going to the hospital more often, who has been going to the emergency room. I actually happen to lead the emerging and urgent care services as well. And so we take a very close look at how many of them are going to the emergency room, how many are being in observation, how many have been admitted, and also working with isolated efforts. Hopefully will be more of those with different groups, either PCP-led groups or multi-specialty, or also cardiology groups where they say, listen, we're going to take care of those patients, don't admit them to the hospital, as we know. And I practiced for almost 20 years. Everybody can argue that not every single person with heart failure needs to be in the hospital the same way that everyone with atrial fibrillation or chest pain. But I think that's another opportunity what we have is work a little bit more on, does this person really need to be in the hospital, or can we take care of this person either proactively or even reactively in a manner that's more efficient and quicker? No, Dr. Neeson said, who wants to be in the hospital? Nobody does. So that's where we have, you know, significant opportunities. We're not there yet, but there's definitely hope that we're going to move in that direction